So I think this patient was treated in quite a standard fashion. He had high-risk localized prostate cancer upon diagnosis. Interestingly, his symptoms that brought him to the primary care physician could have been consistent with prostate cancer, but were true and unrelated. But it did lead his primary care physician to do some workup that led to the prostate cancer diagnosis. As you know, his pain initially certainly was not from prostate cancer since he didn't have bone metastases. But I think the treatment course that he took was very reasonable. For high-risk localized prostate cancer, one would treat that with androgen deprivation therapy and radiation, or with radical prostatectomy. And he chose to undergo androgen deprivation therapy with radiation. Now, his prognosis was not great because after he came off the androgen deprivation therapy, he relapsed quite quickly with a fairly rapid rise in his PSA. So in that situation, after primary local definitive therapy, I think our two most important prognostic markers are looking at when the PSA relapses and PSA doubling time. And his time to relapse was very short, and his PSA doubling time was also very short. So it wasn't surprising that one might find metastatic disease when he underwent re-imaging studies. Now, the treatment of androgen deprivation therapy with abiraterone is reasonable as well, as there's data for abiraterone and androgen deprivation therapy in combination for new metastatic prostate cancer. I will say the caveat is that he was previously treated with localized disease, and that population usually does better than those that present with de novo metastatic prostate cancer. But given his rapid course of relapse, and given his short PSA doubling time, I don't think it was unreasonable to be aggressive and treat him with androgen deprivation therapy and abiraterone as per the STAMPEDE and as per the LATITUDE trials. The data would support that. Now, he was receiving it for the hormone-sensitive disease state, and one would anticipate he might get years of a very low, well-controlled PSA and well-controlled disease. However, about a year later, his PSA started to rise again, which is kind of a short period of response to initial androgen deprivation therapy and abiraterone. One would certainly expect the duration of response for that to be over 2 years, perhaps in the 3-year range. So again, sticking with the trend that he had very aggressive disease. Additionally, sticking with that trend is when he came back to medical attention and treatment change was considered, he actually was already having symptomatic disease with some pain in his femur. Now, he wasn't requiring narcotic pain medications, but it was clearly in a site where he had prior bone metastases. And so I think institution of radium-223 was very reasonable there, as it is regulatory approved and shows a survival benefit for patients with bone metastatic castration-resistant prostate cancer who lack visceral metastases and who have symptoms. And I think that's exactly his situation.